Hello, doctors. I hope everyone is doing well. Just wanted to know, can you hear my voice? Can you hear my voice? If you can hear my voice, let me know because I want us to go through something very, very important today. So please, in the comment section, if you can hear my voice, Dr. Bright, I can see you. Anyone, please, if you can hear my voice, please let me know. Can you hear me? Can you hear me? Awesome. Tonight you guys have a class on QE1. I think it's on orthopedics. And so I wanted to also come your way because a lot of changes are happening in the Medical Council of Canada exams, and especially people are asking, so after QE1, what's next? What I'm going to focus on today will be the exam you write when you want to do your practice ready assessment. Okay, if you want to do your practice ready assessment, this is the exam you write, especially for those who are going into family medicine. So we call that therapeutic decision making. However, I told you in the announcement that it's also good for those who are writing their QE1 and the NACOSCI because of some of the issues we'll be discussing, because some of the issues will be covering a lot of, choosing wisely topics and all those things. So I want you to stick with us because it's very, 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 very important. By the way, if you are joining us, please don't forget to hit on the like and the subscribe button on our YouTube so that we can get this message to as many people as possible. People are trickling in, and that is very, very good. So I'm going to share my screen, and we're going to get into the game right away. Yeah, I think that is my screen. Okay, good. Okay. So, doctors, please, do you see my screen now? Do you see my screen? Okay. So I think I have to do this and do that. Okay, great. So I think this is better, right? Can you see my screen now? I think this is better. Okay. So we're going to get into the class right away. I think what I can do is let me just do it this way. Sorry, I'm just trying to get the presentation so that we can yeah. So let me load it as a slide. Okay, just a few seconds, okay? And then we'll just get it going. By the way, where are you joining me from? Let me know where you are joining me from. I just want to make sure that you can see the slides very, very well. I think the first way I was trying to share the slides, it wasn't going to be easy to see. So I just want you to okay, good. I think I'm now loading the slide. So yeah, we're going to solve a lot of questions tonight, like what we do in every class. So please kindly invite your friends to join us, right away so that we can get it going. I'm just trying to load the slide so that we can study and, get the best out of this. There's a lot of change which is happening so far as the medical council exam is concerned, and the change is also going to affect the TDM exam as well. TDM stands for therapeutic decision making. Okay, therapeutic decision making. So I'm just trying to load the slide so that we can get going. So if you're planning on doing any of the practice ready programs like PRA-BC, practice ready assessment BC, SIPA, the new practice ready assessment, which Ontario has also introduced, then this class is for you. So if you have, a background in general practice, or even you're a specialist and you like to move into family medicine, whatever it is, you will need to take this exam. So, and a lot of people don't talk about this exam because everyone is focused on MCQ1. So I was like, you know what? Let's allow you to see what this exam is about. Good. So I think I've loaded my screen now, so we can move. So when I say change is coming, what do I mean? There's been a lot of change in MCQE1. Now the MCQ1 does not have any CDM, that is clinical decision making. But then when it comes to TDM as well, there is change. And what does this change go for? Why is the medical council making change? And there are 3 reasons why they are making the change. Number 1, they want to enhance the experience you will have as a candidate in the exam. Okay, they want to enhance your experience. Number 2, they also want to increase the efficiency of the exam process. All right, they want to increase the efficiency of the exam process. And number 3, wow, people are joining us from Johannesburg. And number 3, they want to release the exam results quickly. So you realize that that's the same thing they are doing for the MCQE1, and they are bringing the same thing into therapeutic decision making. Now, what level is this exam being tested? What level will this exam be tested at? Okay, what level will this exam be tested at? This exam will be tested at the level of a practicing family doctor. All right, remember that the MCQE1 is tested at the level of a final year medical student. But for therapeutic decision-making exam, if you should pick any regular family doctor who is practicing in Canada, the assumption is that they should be able to pass this exam. Okay, so QE1 is at the level of a graduating medical student. Therapeutic decision-making is at the level of a practicing Canadian medical doctor who is practicing independently. All right. Now, how will the exam be administered? It will be administered globally. At first, you needed to be in Canada to write the exam. But then the medical council has noted that there are some people who are trying to maintain their currency of practice. So they are still in their home countries. Okay. So now, like the QE1, you can write the therapeutic decision-making exam in your home country. So far as you have a prometric test center, which is approved by the medical council, you are good to go. Or you can even write it at home. If you have good internet access, the medical council can arrange for you to get it by remote proctoring. Okay, so the medical council will be updating their website with more information. And because of that, I wanted us to just have a feel of how the upcoming exam will be. So like what we do, we're going to try some questions focusing on the new format. Now, what is the new format about? Initially, the old format, you only provided answers. So it had 40 questions, and according to the medical council, under each of the 40 questions, they had sub-questions. So maybe question 1 can have 2 sub-questions, question 2 can have 3 sub-questions. And according to the medical council, by the time you were done with that exam, you would have answered about 100 questions, even though they are 40. But because they have, breakdowns, you would have answered about 100 questions. Now, the new format is that there's going to be MCQs, all right? There's going to be MCQs for the first part, and then there's going to be the short answer questions for the second part. And there is an optional 20 minutes break. An optional 20 minutes break in between the sections, okay? So remember, you can write this exam from home, anywhere in the world. You can also write it from any prometric center which is approved by the medical council. And it's going to now have 2 sections. The first part will be MCQs. The next part will be short answer questions. So what I'm doing is that we've designed some questions which focus on both MCQs and short answer questions, and we're going to follow up on that. So let's go. So I'm going to read this question to you. Remember, this exam is a bit higher than the MCQE1, especially with the changes. And by the way, someone may be asking me, when will the change be effected? The change will be effected in 2026. So if you're planning on writing your TDM exam this year, it doesn't affect you. But in 2026, that is when it's going to take effect. Okay, so let's try some of the MCQs and see. So you have a 72-year-old man with a history of diabetes mellitus and chronic kidney disease, and he's diagnosed with complicated urinary tract infection. His urine culture grows multi-drug resistant gram-negative organism. Which of the following factors in his history would most strongly suggest the need for empiric broad spectrum antibiotic coverage. Remember also that the TDM exam is basically about management, disease management. So non-pharmacologic management, pharmacologic management, prescription writing, right? Duration of prescription, medication contraindications, medication interactions, medications to be written for children, medication to be written for elderly people, medications and how you're going to assess them if the patient has any renal impairment, medications for pregnant patients. So these are the things you want to look out for. Over-the-counter medications, herbal medications as well. So these are the areas you want to focus on. So let's deal with this particular question. You have a 72-year-old male with a history of diabetes mellitus and chronic kidney disease. He's diagnosed with complicated urinary tract infection. His urine culture grows a multi-drug resistant gram-negative organism. Which of the following factors in his history would most strongly suggest the need for empiric broad-spectrum antibiotic coverage? A, recent use of nitrofurantoin for a prior urinary tract infection. B, recent international travel to a region with high rates of multi-drug resistant organisms. C, history of recurrent UTIs treated with aminoglycosides in the past year. And D, diagnosis of diabetes mellitus without recent hospitalization. Which of the following factors in his history would most strongly suggest the need for empiric broad-spectrum antibiotic coverage? Doctor, so please just type your answer in the comment section. Type your answer, type your answer, type your answer. Let's go. I want to see the answers you're going to type, okay? Type your answer. Let's go. Looks like you guys are quiet. So you see, that is what the TDM exam is not. So far as you prepare for it well, using the appropriate materials, you should be fine. Okay. So what is the answer here? Can anyone help us? Can you help us? What's the answer here? Okay. Good. So the answer here is recent international travel to a region with high rates of multi-drug resistant organisms. So the answer is B. And the teaching point is this. Risk factors for multiple drug resistant UTI include recent hospitalization, okay, prior use of fluoroquinolones or prior use of trimethoprim sulfamethoxazole or a broad spectrum beta-lactam, okay, and then travel to regions with high rates of multi-drug resistant organisms. So that is why the answer was B. Nitrofurantoin is not associated with multi-drug resistant urinary tract infections, and aminoglycosides are less commonly linked to resistance compared to beta-lactams and fluoroquinolones, okay? And diabetes is a risk factor for complicated UTI, but it's not specifically a risk factor for multi-drug resistance. So that is why the answer is B. Now, let's go to another question. So you realize that this exam is more on management, right? Prescriptions and all those things. So this question says, you have a 32-year-old non-pregnant female who presents with acute uncomplicated cystitis. She has no history of multi-drug resistant infections and there is no concern for early pyelonephritis. Her estimated glomerular filtration rate, eGFR. So remember that I told you that one other place you want to focus on is, medication adjustments for patients with kidney impairment, right? So his estimated glomerular filtration rate is 25 mils per minute. Which of the following is the most appropriate first-line treatment option? A, nitrofurantoin 100 milligrams orally twice daily for 5 days. B, trimethoprim sulfamethoxazole 160 milligram over 800 milligram orally twice daily for 3 days. Phosphomycin 3 grams orally as a single dose, and pivamesilinum 400 milligrams orally 3 times daily for 5 days. Which of these is an appropriate antibiotic for a patient with uncomplicated cystitis with estimated GFR, which is 25? Is it A, is it B, is it C, or is it D? What's the correct answer? I see someone is going for B there. Any other answer? Will anyone else try? Good. Dr. Bright went for C. Any other answer? Or will somebody agree with A, B, C, or D? And what's the correct answer? So I'm just trying to introduce you to these concepts. And the correct answer is C. C, fosfomycin 3 grams orally as a single dose. Why? You realize that when you're preparing for your TDM, we will teach you that nitrofurantoin should be avoided in patients whose creatinine clearance is less than 30 mils per minute. Why? Because there is inadequate urinary concentration and potential for systemic toxicity. So you want to avoid nitrofurantoin in patients whose creatinine clearance is less than 30. Trimethoprim sulfamethoxazole, which is B, is a good option, but it should be avoided in a lot of regions where resistance exceeds 20%. So it goes down in the pecking order. But fosfomycin retains its activity against multi-drug resistant organisms and is a preferred choice for patients who cannot use nitrofurantoin because they have renal impairment. That is why we went for C. And pivamesilanam is not well studied in males. Remember that. And while it is effective in females, it is not the best option when fosfomycin is a safe alternative. So today, the learning point for this particular one is that if you have a patient who has renal impairment and the creatinine clearance is less than 30, one medication which is safe for the management of UTI in those patients is fosfomycin. Okay? Fosfomycin. I have another question for you. Doctors, I hope that you are getting a feel of TDM and how changes are going to apply in the coming year, 2026. So if you are planning on writing your TDM in 2026, what we will do is that we will start preparation for the 2026 exam very early, okay? But currently, we are taking enrollment for those who are going for the exam in May. Classes will start on March 26th, and I'll talk to you about that at the end of the class. But I just want you to understand that if you are preparing for TDM for 2026, be prepared for MCQs as well, okay? Be prepared for MCQs. So someone is asking a question here that how will this option differ in case of MCQ1? Okay, so I think one of the things you need to notice is even in the mock exams that we conduct and everything, typically we don't focus a lot on doses, drug medication doses and everything. Remember that the TDM, I said it initially, that it's at the level of a practicing doctor in Canada. MCQ1 is at the level of a graduating medical student, okay? So that is where the difference comes in. Okay, good. So let's continue. Yep, a 68-year-old non-pregnant woman presents with dysuria, frequency, and urgency. She has no fever, no flank pain, and no history of recurrent UTIs. Her renal function is normal, with a creatinine clearance of more than 60 mils per minute. You decide to start empiric therapy. Which of the following is the most appropriate first-line treatment for her? A, nitrofurantoin 100 milligrams orally twice daily for 5 days. B, ciprofloxacin 500 milligrams orally twice daily for 3 days. C, amoxicillin clavulanic acid 875 milligrams orally twice daily for 5 days. And D, levofloxacin 500 milligrams orally daily for 3 days. What's the correct answer there? What's the correct answer? What's the correct answer there? Doctors, while we are on, don't forget to subscribe to our YouTube channel. Don't forget to subscribe to our YouTube channel so we can grow it and, get as many people as possible all over the world to enjoy some of these lectures as well, okay? Don't forget to subscribe to our YouTube channel. So what is the correct answer? Okay, so I see that Dr. Serge MP, who is joining us from South Africa, went for A. Dr. Bright also went for A. And Dr. Titi Lope also went for A. What's the correct answer? The answer is A. Nitrofurantoin is the preferred first-line option for acute, uncomplicated cystitis, with about 99% of E. coli, which is susceptible despite resistant trends in older adults. Okay, now fluoroquinolones are reserved for complicated infections. So I know that many of us have different practices all over the world, but in Canada, nitrofurantoin is one of your first line medications. You want to use ciprofloxacin and levofloxacin and all those things if the patient rather presents with complicated UTI. Okay, now amoxicillin clavulanic acid is not a first-line agent due to inferior efficacy against uropathogens compared to nitrofurantoin. So if you want to learn your first-line antibiotic for UTI, you want to look at nitrofurantoin as one of them. Doctors, please, I have a question. Is the class making some sense now? Is it really opening our eyes to certain things? Is it really doing that? I need to shut down my window because it looks like it's shining some light on my face. So let me just, okay, I think this is better. Oh my goodness, my face has become too dark. Okay, so I think this is better. Okay, so doctors, is this shining some light onto the TDM exam for you to come to appreciate, exactly what you should expect in the exam? Okay, let's go for another question. You have a 32-year-old woman who presents with her first episode of acute uncomplicated cystitis. She has no history of multi-drug resistance organisms, and she has not taken any antibiotics in the past 6 months. Based on current recommendations, which of the following is true regarding her management? A urine culture is required before initiating antibiotics. B, fluoroquinolones are first-line therapy in this patient's setting. C, fosfomycin should be avoided due to inferior clinical cure rate. And D, if she has no symptom improvement within 48 to 72 hours of antibiotics, reassessment is required. Which of the following is true regarding hair management? Which of the following is true regarding hair management? Which of the following is true regarding this patient's management? Is it A? Is it B? Is it C? Is it D? So Dr. Serge went for D. Serge MP went for D. Dr. Irum Wakas went for A. Dr. Sekina Abiola Adewale is going for D. And looks like Dr. Bright is also going for D. Dr. Titilope went for D as well. And the correct answer is D. If she has no symptom improvement within 48 to 72 hours of antibiotics, reassessment is required. Okay, urine culture is rarely required in females with uncomplicated cystitis unless there are risk factors such as recent antibiotic use. So A is wrong, because we're looking for what was the correct answer, and the A was saying that you need urine culture before you start antibiotics, but that is not true. Why is B wrong? Fluoroquinolones should be reserved due to resistance concerns and serious adverse events. Because of, fluoroquinolones can cause tendinopathy. Fluoroquinolones can also cause CNS toxicity, right? And then fosfomycin is a first-line option, even though its resistance towards, or even though it retains activity against multi-drug resistance, it's it has a mixed clinical data. So most of the time you want to go for D, which says that if she has no symptom improvement within 48 to 72 hours of antibiotic use, you want to reassess the patient. Okay, let's do another question. You have a 40-year-old female who presents with recurrent, this time the question is recurrent uncomplicated cystitis. That is, she's had more than or equal to 3 culture-positive UTIs in the past 12 months. She's reluctant to take continuous antibiotics and prefers non-pharmacologic options. Which of the following is the best recommendation to reduce UTI recurrence? If somebody wants to prevent recurrent UTIs, What's the best non-pharmacologic treatment option? A, increase hydration to 1.5 liters of water every day. B, use spermicides regularly with sexual activity. C, apply topical estrogen in all women, regardless of menopausal status. And D, avoid cranberry products as they have no proven benefits. What's your answer? Is it A? Is it B? Is it C? Or is it D? What's the correct answer, doctors? I'm waiting for your answer. So Dr. Talent went for A. Dr. Bright also went for A. And the correct answer is A, right? Hydration significantly reduces recurrent UTIs based on randomized control trial data. Okay. Remember, this exam is at the level of a medical doctor who is practicing. QE1 is at the level of a medical student who is graduating. Okay. And spermicides should be avoided as they are associated with increased risk of UTI. So spermicides rather increase the risk of UTI, while hydration reduces the risk of recurrent UTI. Okay. Topical estrogen is only beneficial for postmenopausal women who have atrophic changes. And so you don't want to just use it in all women. Okay. And cranberry products have mixed efficacy, but may still be considered in some patients. But with all the options you had there, the correct answer you want to go for is A. Okay. Next question. You have a 29-year-old female who experiences recurrent uncomplicated cystitis, often occurring within 24 to 48 hours after intercourse. So Dr. Ajayi is asking, is this a TDM or QE1 class? It is both. It is mainly a TDM class, but it's also covering some QE1 concepts, okay? I just want to show his question. He said, is this a TDM or a QE1 class? It is mainly a TDM class, but it also covers some QE1 concepts as well. So if you are preparing for a QE1, this will help you. If you are preparing for TDM, this will super help you, okay? Good. So you have a 29-year-old female who experiences recurrent uncomplicated cystitis, often occurring within 24 to 48 hours after intercourse. She prefers antibiotic prophylaxis only around the time of sexual activity. Which of the following is the most appropriate regimen? A, nitrofurantoin 100 milligrams orally once daily for 6 months. B, trimethoprim sulfamethoxazole 40 to 200 milligrams orally once daily. C, cephalexin 125 to 250 milligrams taken as a single dose after intercourse. And D, fluoroquinolones like ciprofloxacin or norfloxacin taken for 3 days after intercourse. So what is the most appropriate regimen for this patient? So doctors, I just want to psych you, especially those who are going for the TDM exam, okay? If you are planning on going for your practice ready assessment, I just want to psych you that, this is how you want to start thinking at the level of a doctor who is practicing in Canada, okay? So what's the correct answer? What's the correct answer? Some are going for B. What's the correct answer? The correct answer will be C. That is cephalexin, 125 to 250 milligrams, taken as a single dose post-intercourse, okay? So postcoital prophylaxis is effective for patients whose UTIs are linked with sexual activity. That is why there are some people, we even call some having honeymoon urethritis, right? Honeymoon urethritis, like the patient tends to develop UTI after sexual intercourse with their partner, okay? And cephalexin is a valid choice for postcoital prophylaxis. So if the patient wants to avoid UTIs post-coitus, what they can do is that they can take a single dose of 250 milligrams or 125 milligrams of cephalexin after sexual intercourse, okay? And continuous prophylaxis is not necessary because she is looking for postcoital dosing. And what you also want to be careful about is that you want to avoid fluoroquinolones unless no other options are available due to the issue of resistance. So you also want to avoid fluoroquinolones due to the issue of resistance, especially when you want to give prophylaxis for recurrent UTIs. Okay. All right. Let's go to the next question. So you have a 65-year-old postmenopausal woman who has 5 culture-confirmed uncomplicated UTIs in the past year. So in other words, the patient has had 5 UTIs and it was confirmed with urine culture. So she completed a full treatment course for the most recent UTI, and her urine culture 1 week post-treatment is negative. You consider starting continuous prophylaxis, which of the following is true regarding long-term antibiotic use for UTI prevention. A. Continuous prophylaxis reduces UTIs but increases antibiotic resistance risks. B. Antibiotic prophylaxis should be indefinite for all patients with recurrent UTI. C. Patients should not be reevaluated after starting prophylaxis unless symptoms worsen. And D. Fluoroquinolones are preferred agents for continuous UTI prophylaxis. What's the correct answer? Is it A? Is it B? Is it C? Or is it D? What's the correct answer? I just want to give you time to answer. Sure. So it looks like a lot of people are going for A, and the correct answer is A. So continuous prophylaxis reduces UTIs but increases antibiotic resistance. Okay. Continuous prophylaxis. So the explanation is that continuous prophylaxis lowers UTI recurrence rates, but resistance is also a concern. Okay. So the number needed to treat for continuous prophylaxis is 12, but resistance increases as well. And prophylaxis should be reconsidered after 6 to 12 months. That is incorrect. And regular follow-up and periodic urine cultures are needed. That's also incorrect. In fact, if you review some choosing wisely concepts, you realize that there's no need to do regular follow-up and periodic urine cultures. And fluoroquinolones should be avoided unless absolutely necessary. It's also incorrect. Okay, next question. So you have a 76-year-old woman with asymptomatic bacteria. She's evaluated at the long-term care facility. She has no fever, dysuria, or systemic symptoms, but a routine urine culture ordered by her physician shows more than 10 to the power 5 CFU per mil of E. coli. Based on the current guidelines, what's the next best step? A. Start nitrofurantoin 100 milligrams orally twice daily for 5 days. B. Start ciprofloxacin 500 milligrams orally twice daily for 7 days. C. Reassure the patient and avoid treatment. And D. Repeat urine culture and start empiric amoxicillin clavulanic acid. So this is where, in fact, you realize that TDM and QE1 tend to meet, right? Because this is also a QE1 concept, asymptomatic bacteriuria. So if you go into your QE1 portal, you realize that asymptomatic bacteria is dealt with in detail, right? And this particular patient, so what are you going to do? Are you going to start on nitrofurantoin? Are you going to start on ciprofloxacin? Are you going to just reassure her? Or are you going to repeat the urine culture and start empiric amoxicillin clavulanic acid? What will you do for this patient? What will you do for this patient? Dr. Kim says he's going to go for C. Dr. Bright also will go for C. So you realize that if you're even preparing for QE1, you will have a very good idea. Dr. Shiner is also going to go for C. Dr. Serge MP is going for A. The correct answer is C. C. You remember that asymptomatic bacteria should not be treated in older adults in long-term care facility due to lack of morbidity mortality benefit, and it increases antibiotic resistance risk, right? So that's why we went for C. You don't want to treat asymptomatic bacteria in long-term care patients? Doctors, next question. So today I just want to quiz you a lot. I want to use the new format for the exam to quiz you a lot. And then after that, we will also go into some of the short answer question and answers as well. Okay, so let's go. So you have a 35-year-old woman who presents the history of 3 culture-confirmed UTIs in the past 12 months. She reports that her symptoms often occur within 24 to 48 hours after. I think we've already dealt with this question, so I'm not going to waste your time. We've already dealt with this question. Okay, so let's do this. You have a 28-year-old woman who experiences 2 uncomplicated UTIs in the past 6 months, but prefers to avoid daily antibiotics. She's comfortable recognizing early symptoms and wants self-manage future infections. What's the most appropriate management plan? A, provide a prescription for a short course of antibiotic to use at symptom onset. B, start nitrofurantoin 250 milligrams daily for 6 months. C, prescribed post-coital prophylaxis with trimethoprim sulfamethoxazole 4,200 milligrams. And D, recommend cystoscopy to rule out structural abnormalities. What's your answer? Are you going to go for A? Are you going to go for B? Are you going to go for C or D? Doctors, don't forget to click and subscribe to the YouTube channel. Okay, so what is going to be your answer? Are you going to go for A, for B, for C, or for D? What is your answer, doctors? All right. So the answer here is A. You want to prescribe a short course of antibiotic to use as symptom onset. Remember that this patient said something here. If you look at the question very well, she's comfortable recognizing early symptoms and wants self-manage future infections. So usually you want to look for cases where the patient can manage their UTI. So this one, they can have the antibiotics on hand. As soon as they start experiencing the dysuria frequency and all that, then they take it. I can see why a lot of you are going for D, because we talked about UTI prophylaxis, but that was for UTI prophylaxis post-coitus, right? This one, the patient is asking, what can I do assuming my UTI symptoms start? So the doctor can prescribe some antibiotics, the patient can keep on hand, and as soon as UTI starts, the patient can use it. Okay. So now let's move from the MCQs to the short answer options. So I'm going to give you a clinical scenario where you have a 75-year-old woman who presents with dysuria, new onset urinary incontinence, and flank pain. Temperature is 38.2 degrees Celsius, no history of catheter use, no prior UTIs. Based on this clinical vignette, what's the most likely diagnosis? Doctors, let's go. Let's not take time at all. Let's just keep going. Based on the clinical vignette, what's the most likely diagnosis? So this one, you have to provide the answer. So this is how the afternoon session will be like. The morning session is, or the first part is what we did, MCQs. Now you have to provide answers, okay? Now you have to provide answers. Okay. So Dr. Sakina Abiola Adewale says pyelonephritis. Dr. Shana also says pyelonephritis. Dr. Kim also says pyelonephritis. The answer is acute pyelonephritis, and that is correct. Beautiful. Everyone else is going for pyelonephritis. Dr. Titilope is going for pyelonephritis as well. Next question. List 4 non-pharmacological strategies to manage UTIs in older adults. So you have to provide the answer. Please type your answers right away. Non-pharmacologic strategies to manage UTIs in older adults. Type your answers right away. Type your answers. Non-pharmacologic management strategies. So what are the non-pharmacologic strategies? Number one, you want to encourage increased fluid intake. Beautiful. So Dr. Wakas said hydration. So Dr. Wakas, you want to be more specific, right? Encourage increased fluid intake. Okay. Number two, frequent toileting to avoid retention. So if the patient feels like peeing, she should use the washroom. Number three, educate about proper perineal hygiene. They should clean from front to back, not back to front, because back to front introduces some of the organisms from the anal region to the vaginal region. Okay, and then use cranberry products or probiotics, but that one has limited evidence. So first, what are the things we can do to prevent UTIs non-pharmacologically? Encourage increased fluid intake, frequent toileting to avoid retention, educate about proper perineal hygiene, and use cranberry products or probiotics. Okay, good. Next question. What are the pharmacologic options for managing a UTI in older adults, considering the first-line treatment for uncomplicated UTIs? So remember that I've already taught this, so I'm just going to go through it. What are you going to do? The first line is nitrofurantoin. You can also use medications like trimethoprim sulfamethoxazole or cefalexin. So your first line, unless contraindicated, is nitrofurantoin. And we learned that one of the contraindications for nitrofurantoin is if the patient's creatinine clearance is less than 30, right? And second line options are trimethoprim sulfamethoxazole and cefalexin. Okay, next one. What's the most appropriate medication for managing UTI in a pregnant patient? I think someone asked this question. I'm going to go back and look for someone asked this question somewhere. Yes. Dr. Paris, beautiful Paris. That's the name. He said, can it be used in pregnant women? So now this question is coming back. Remember that I told you that when you're learning for TDM, you have to review. Like if you are dealing with UTI, for example, let me give you an example. If you're dealing with UTI, you have to learn UTI in children, UTI in adults, recurrent UTI, complicated UTI, UTI in patients who use urinary catheter, asymptomatic bacteriuria, right? Then you also want to deal with UTI in pregnant patients. And then you want to go into medications used for managing UTIs. You want to look at first-line medications. You want to look at contraindications. You want to look at medication interactions. And then finally, you want to learn medication prescription. So if you pick UTI alone, there are so many things you need to know so far as UTI is concerned. So what is the most appropriate medication in the management of UTI in pregnant patients? And I think people are going for nitrofurantoin. I don't really know whether they are trying to answer this question or they are good. And so for pregnant patients, you want to use things like amoxicillin and cefalexin, right? Because nitrofurantoin can create a little problem there. Now, what's the most appropriate medication for managing UTI in a patient with renal impairment and creatinine clearance is less than 30? I think we've already talked about it. So you see the way the concepts are repeating, right? So if creatinine clearance is less than 30, you want to use cefalexin because nitrofurantoin is contraindicated, right? If creatinine clearance is less than 30, please don't use nitrofurantoin. Rather use cefalexin because nitrofurantoin is contraindicated. Okay. Now, this is another point. Write a prescription for 4 different medications that can be used to treat uncomplicated UTIs. So we learned that we can use cefalexin, we can use trimethoprim sulfamethoxazole, we can use nitrofurantoin. So it is not enough to know the names of the medications. You must also need to know how to write a prescription. Okay, how to write a prescription. How to write a prescription. So I'm going to show you some of the prescriptions. You can do nitrofurantoin 100 milligrams twice a day for 5 days. You can also do cefalexin 500 milligrams PO, BID, or even some people can even do QID 4 times a day for 5 to 7 days. Now, this is something I want you to learn. The 5 to 7 days I wrote there is for teaching purposes. It is for teaching purposes. In other words, I'm just trying to say that you can prescribe it for 5 days. You can also prescribe it for 7 days. In the exam, don't write a range. Don't write, for example, cefalexin 250 to 500 milligrams, and don't write 5 to 7 days. Why? Because that is wrong. If you are going for 5 days, go for 5 days. If you are going for 7 days, go for 7 days. Okay. And then we also have trimethoprim sulfamethoxazole, 800 milligrams over 160 milligrams BID for 3 days. Okay. And then we also have fosfomycin 3 grams by mouth as a single dose. So these are all options. These are all options for the management of UTI, and you must know how to write a prescription. Dr. Shayna, you want to be very careful because the question is asking about first line. Levofloxacin and the fluoroquinolones will be used as second line, okay, or for complicated UTI. So if you see here, I wrote that do not write a day or dosage ranges in the exam. This is for teaching purposes also. So don't write 5 to 7 days. Don't write 250 to 500 milligrams. No, if you are going with 250 milligrams, just write 250 milligrams and go. Because we know that prescriptions at times have a wide range, right? And so far as what you're writing is in the range, you'll be correct. Okay. So list potential drug interactions with the medications prescribed. So in other words, what's the potential drug interactions with nitrofurantoin, cefalexin, trimethoprim sulfamethoxazole, and all those things? What are the potential drug interactions? Nitrofurantoin will interact with antacids. Okay. Trimethoprim sulfamethoxazole will increase the risk of hyperkalemia if it is used alongside ACE inhibitors or ARBs. So ACE inhibitors examples is ramipril, lisinopril, captopril, right? And ARB's example is losartan. So if you use trimethoprim sulfamethoxazole with an ACE inhibitor, there's a risk of hyperkalemia. And this is where TDM and QE1 crossover. So for QE1 exam takers, you need to know your ECG findings of hyperkalemia, tall tented T waves, and all those things, and how you're going to manage hyperkalemia, right? Because one of the MCC QE1 objectives is potassium abnormalities. So you must know how to manage hyperkalemia. You must learn how to manage hypokalemia. And we are learning today that trimethoprim sulfamethoxazole, if you combine it with ACE inhibitors or ARBs, there's a risk of hyperkalemia. Okay. And one other thing, cefalexin interacts with metformin, and there's a risk of hypoglycemia. So these are some of the drug interactions you want to learn. Okay, so list the common side effects of each of the medications prescribed. So in other words, you must learn the side effects of nitrofurantoin, the side effects of trimethoprim sulfamethoxazole, the side effects of cefalexin, all those side effects, you must learn them. And these are the things we teach at MedCognito to make sure that you are well equipped and well prepared for your exam. Doctors, I have a question. Is the class making sense now? Is it making sense for you right now? Like, are you able to pick up the pieces and where we are laying the axe? Because I really want you to come to appreciate, the extent to which you must know for the TDM exam. Okay. So what are the side effects? Nitrofurantoin can lead to gastrointestinal upset, pulmonary toxicity as well. Okay. So nitrofurantoin can lead to those things. Trimethoprim sulfamethoxazole can lead to rash, Stevens-Johnson syndrome, hyperkalemia. We said hyperkalemia happens if you combine trimethoprim sulfamethoxazole with an ACE inhibitor or with an ARB. And cefalexin can lead to diarrhea or hypersensitivity reactions. Okay, good. Now let's go to another question. So you have a 70-year-old male with a history of benign prostatic hyperplasia, BPH, and he presents with fever, 38.5 degrees Celsius, chills, flank pain for the past 24 hours. He also has noticed increased urinary urgency and frequency. His urine dipstick shows nitrites and leukocytes. He's diagnosed with pyelonephritis. What's the appropriate empiric antibiotic therapy for this patient? So you have a male who has developed pyelonephritis, What is your management? What medication will you give? What medication will you give to this particular patient? What medication will you give, doctors? I want to know. What medication will you give? What's the appropriate antibiotic? And you realize that Dr. Shana is saying intravenous. Well, Dr. Shana, the question is, what is the appropriate empiric antibiotic? So the question is looking for the name. The name, it's not looking for the root. It's looking for the name of the antibiotic. And the name of the antibiotic is ciprofloxacin. Or you can use trimethoprim sulfamethoxazole, right? Because don't forget that pyelonephritis means we are dealing with a complicated UTI. So ciprofloxacin is the first line empiric therapy for pyelonephritis, especially if there is no contraindication. Okay, Dr. Celebration Collins, remember that we use nitrofurantoin for uncomplicated UTIs. We'll go with Cipro, and alternatively, you can use trimethoprim sulfamethoxazole. I'm really enjoying this class, seriously. So another question. A 68-year-old woman with type 2 diabetes presents with symptoms of pyelonephritis, including fever, flank pain, and dysuria. Her past medical history, this patient's past medical history includes chronic kidney disease, stage 3, and her estimated creatinine clearance is 25 mils per minute. She is allergic to sulfur drugs. Which of the following antibiotics should be avoided in this patient for treating complicated UTI? A, ciprofloxacin. B, nitrofurantoin. C, cefalexin. D, amoxicillin clavulanic acid. What's the correct answer? What's the correct answer, doctors? So B, nitrofurantoin again. So you realize that nitrofurantoin and low creatinine clearance is a very important high yield concept I really want you to understand today. Okay, good. So I want to ask you this other question. You have a 50-year-old postmenopausal woman who presents to your clinic with recurrent urinary tract infections. Okay, with recurrent urinary tract infections. She has had 3 culture positive UTIs in the past 6 months. Each time her urine culture grows E. coli, which was sensitive to nitrofurantoin. She does not have any structural abnormalities in her urinary tract infection. Urinary tract. What strategy could help reduce the risk of recurrent UTIs in this patient? What strategy? We've already dealt with it in the MCQs, so I'm just going through them. One strategy you can use is to give them vaginal estrogen cream, right? Because in postmenopausal women, vaginal estrogen has been shown to reduce the incidence of recurrent UTIs by improving the health of the vaginal epithelium. Vaginal estrogen. Okay, so the last question, I think Dr. God's favor, Ihema Bright said, the complicated threw me off. No worries, doctors. That is why we are also here to learn. Okay. So in postmenopausal women, if you want one strategy which will reduce the fact that UTIs recur, one of them is to get vaginal estrogen cream. It's very, very important. Okay. So, doctors, that is, one thing I want to draw attention to. There are changes occurring all across, the entry portal for doctors like you and me trying to get into Canada. And TDM is one of them. Come January, so those who missed that part, come January 2026, the TDM is also going to change a little bit. There's going to be MCQs and there's going to be filling. So that means that you can't learn surface stuff. Number 2, you also have to understand that the TDM is being tested at a level of a practicing doctor in Canada. Okay. So, and this is the story of many people. So Dr. Shana Agaral, says this appears similar to CDM. Yes. Yes. So the second part appears similar to CDM, and the first part appears similar to the new format for the MCCQE1, okay, which is MCQs alone. So this time you're going to do both MCQs and CDMs together. And this is the story of many doctors, whether they are preparing for QE1 or for NACOSQ or for TDM. Dr. Bruni, I'm stressed. How do I study the entire CTC? And you realize that CTC is a very big book, right? It's a very, very big book. So that's what we have, been doing. Now, this doctor, Dr. Mangala, is from Sri Lanka. He was a pediatric surgeon in Sri Lanka, and a lot of the people from Sri Lanka know him. He's currently practicing in Saskatchewan. He went through our hands, and this is what he said. So he's currently, I don't know the community he's practicing in because I'm also in Saskatchewan, but he says, I can guarantee this is a course with 100% success rate if done with determination and effort. I did my TDM living out of Canada with my busy medical practice because he had to go home and I think go and get his currency of practice or so. But this TDM course was the only material I used to pass my TDM comfortably. Okay, so this is somebody from Sri Lanka. He came in, he conquered it, he did it. Another person also said something to me. He said, Dr. Nana, because that's also my other name. My name is long. Many of you know me as Dr. Bruni, but another part of my name is Dr. Nana. Thanks for all your input and help. I passed the TDM. Next, wish me luck with the rest of the process. I hope you can guide me through. And this doctor is also currently practicing in Saskatchewan as well. He also went through TDM, went through the SIPA program, and he's practicing in Saskatchewan. And then Dr. Neslejan took her TDM while she was in the Netherlands. She's currently practicing in Alberta. Okay, so doctors, I'm just trying to let you know that it is doable. Many doctors have done it, and you can also do it. I've shown you somebody from Sri Lanka. This other doctor who sent me this message is from Iran. Okay, Dr. Neslejan as well. We have so many Nigerians, so many Ghanaians, so many South Africans, so many people from Pakistan and Bangladesh who have also aced the exam. And a lot of doctors who are also coming from UK. Some of them may not have the UK license, and so they have to write the QE1 and the NACOSQ and the TDM. Okay, so what is the TDM all about? Aside the changes which are happening, what's the TDM all about? So if you can see my page very well, I'm just going to check if I can enlarge it. The TDM is going to cover, especially when it comes to the fill-in part, okay? The fill-in part. It's going to cover health promotion and illness prevention. It's going to cover acute medicine, that is emergency medicine. It's going to cover chronic medicine, and it's going to cover safety and adverse effects. Okay? So, and then the questions are distributed according to pharmacologic and non-pharmacologic management. Okay? So, for example, 70% of the questions will be focused on pharmacologic management. That is medication names, medication writing, doses, drug interactions, contraindications, and 30% of the questions will focus on non-pharmacologic management. So 30% will focus on pharmacologic, 70% will focus on non-pharmacologic. Okay? And don't forget that the questions will be distributed according to health promotion. So that is prevention of conditions, acute medicine, chronic and drug safety and adverse effects. Now, if you look at the way they distribute the questions, 10 of the questions out of the 40 will focus on acute medicine, that's emergency medicine. 12 of the questions will focus on chronic medicine. So assuming I'm taking something like diabetes, okay? Or let me even use the UTI we just used today. So acute issues, you're thinking about things like pyelonephritis, a patient who has kidney stone with fever, okay? Then the chronic will be like recurrent UTIs and all those things. Then safety and adverse effects can maybe focus on things like, will you give antibiotics to a patient who lives in a long-term care facility with asymptomatic bacteria? And then health promotion and illness prevention is if the patient has had recurrent UTIs and the patient wants to avoid the recurrent UTIs, what can be done? So please, doctors, when you are learning this, always remember 70% of the cases will come from pharmacologic, 30% will come from non-pharmacologic. Aside that, you have to learn the emergency medicine part of it, chronic medical condition part of that, safety and adverse effects, as well as health promotion and illness prevention. Doctors, please, have I communicated clearly to you today? Is it clear? Is it clear now? I really want to know, is it clear? So the TDM is nothing to be afraid of. It's an exam. The medical counselor has already given a lot of things you need to know, and that is exactly how we focus our teaching. So I want to know, is this class making sense at all? Is it making sense to you? Good. Okay. All right. So now my next slide is going to talk about what should be your focus when you're preparing for this exam. You should look at health promotion and illness prevention. That is public health. So that is where vaccinations will come in, contraindications to some vaccines, all those things. Acute illness, where you're looking at ER situations, admission orders. When are you going to, refer to a specialist? When are you going to consult a specialist? Okay. And then chronic disease, chronic disease management. So you take something like diabetes. What are the long-term complications of diabetes and how do you manage them? And then safety profile of medications, opioids, benzodiazepines, right? Drug classes. So you must don't just learn the names of the drugs. So don't just learn amoxicillin, learn the class of amoxicillin as well. And don't also forget to learn prescription writing. And while you are learning, don't just focus on, let me see, this doctor says, yes, Dr. Bruni, the class is making so much sense like sentence. That's good. Okay, so don't just learn first line treatments. No, go a little deeper. Focus on second line, focus on third line, focus on adverse effects, focus on alternative therapies. Okay, focus on therapeutic contracts. So in which drug classifications are you going to use therapeutic contracts, like benzodiazepines, like opioids, like controlled substances, right? Where you have to give a therapeutic contract. You have to also learn drug misuse and abuse, because that is happening a lot in the healthcare system. And if you are going to become a doctor who is practicing at the level of a doctor in Canada, you must know all these things. That's why I want to, focus and make sure that we deal with this. So doctors, the stakes are very high. Like the QE one, you have 4 attempts at 4 attempts, right? And if you pass, and I think after 2 years or so, you've not been called into practice with the assessment, you need to retake the exam again. And if you take it for the second time and after 2 years again, you're not called, that is it. I don't know whether they're going to make changes to it, like the way if you pass Q1, you've passed forever, right? So, for example, if somebody should fail the exam, they cannot take it that same year. They'll have to wait for the next calendar year to take the exam. That's why you want to make your first. It's not like the QE1 where someone can maybe not do well in January and can go for the May exam. For TDM, if the person does not pass the exam in, say, 2025, the person cannot go for the exam in 2025 again until 2026. Okay. And so you cannot apply for consecutive exam sessions. And Canadian guidelines and best practices are what you need. That is why at MedCognito, we take our time and make sure that we are focusing on Canadian guidelines only, right? So how are you going to ace your exam? You've got to follow the guidelines. 1, especially in the afternoon session, you've got to write only 1 answer per line. Number 2, you've got to provide only the number of responses that are required. So if they want 4 responses, you provide 4. And responses will be scored in the order they appear in the text box. And any remaining responses will not be scored. And there are times if you think there's no need for treatment, like that asymptomatic bacteria question I was talking to you about, which I quizzed you on, you can just say no treatment. And if you write a wrong response, no points will be deducted. The other point is that you want to be brief and you want to be specific. Don't say thyroid disease, rather say hypothyroidism or hyperthyroidism. Don't say heart disease. Rather say acute myocardial infarction or angina pectoris or whatever heart disease the patient has, right? And also ask yourself, is this question about a drug or a drug name? Or drug class or a drug name? If it's a drug class like fluoroquinolone and you go and write ciprofloxacin, wrong. If it's about a drug name as well, and you go like if they're expecting something like amoxicillin and you go and write penicillin, that's also wrong. Okay, and do not provide a range. I said this before and I'll say it again. If I provide a range when I'm teaching, it is just for teaching purposes, and usually I'll write it there that if I'm providing a range, it's just for teaching purposes, right? Don't provide a range. If you're writing, just write 7 days or 5 days. Don't write 5 to 7 days. That is wrong. You are not going to be penalized for wrong spelling mistakes. So far as the examiner knows exactly what you're trying to write, if you miss an I or an A, it is not wrong. And what about abbreviations? Use only abbreviations which are commonly known across Canada, or at best, don't use abbreviations at all in your exam. All right, doctors? So this is it. Like, I want you to also know, you can take a screenshot of this. What are the materials you need to learn? Canadian Patient Safety Institute materials, the safety competencies, enhancing patient safety across the health professions, 2nd edition, World Health Organization and International Statistical Classification of Diseases, 11th revision. Alberta Health Services, they have a book called Bugs and Drugs. In fact, I had a copy, but I think I've taken it home. I would have shown you. It's called Bugs and Drugs, okay? Then UpToDate.com is also a very, very good resource. And Public Health Agency of Canada, their infectious disease portal. And Public Health Agency of Canada, immunization guide. And College of Family Physicians of Canada, priority topics and key features in assessment of objectives for certification in family medicine. So initially, that particular one, the College of Family Physicians of Canada, they had only 99 topics. But since 2021, they have changed the number of topics from 99 to 105 topics. Okay. So if you go to their priority topic list, it's there. That is why I'm telling you that this exam is at the level of a practicing medical doctor. Okay. Then you can also use Choosing Wisely Canada and Canadian Medical Association Journal, CMAJ, RX files as well. Okay. So I'm just going to, you can get RX files, you can get it online. If you are not in Saskatchewan, I think you just have to pay for it. But if you are in Saskatchewan, you can get it for free. Okay, so I'll just share that, like how RX files looks like. Let me just show you how RX files looks like. Like if you want to see it online, okay, I'm just sharing it with you so you see it. So this is RX files, okay? Doctors, please, can you see it? This is RX files. And if you go to portal of our resources, portal to our resources, if you click that, it will bring you here. All you need to do is to click this, okay? Remember, if you're in Saskatchewan, you get it for free. If you're in Saskatchewan, you get it for free. But if you're, because RX files is developed in Saskatchewan, it was developed in Saskatchewan. So if you're in Saskatchewan, you get it for free, okay? So if you click here, then you can go to the table of contents, okay? And the table of contents. So if you want to learn something about angina, you click on angina. If you click on angina, I'm just going to look for the and then share the page with you. Good. So if you want to learn about angina, you just go there, click on it, and boom, everything you need to learn is there. All right? Okay. Good. So doctors, let me not waste your time with that. So if you want RX files, just type RX files in your Google search, okay? And then they also have the compendium of therapeutic choices. But someone will say, Dr. Bruni, all these things are too many. What do I do? That is where MedCognito comes in, okay? We've summarized everything for you. So psychiatry, neurology, ophthalmology, endocrinology, cardiology, and then so each portal has what you need. And we also get replay of the live classes as well. As part of it as well, in the MedCognito portal, you also have mock exams, which you will do. And because of the changes, we've also developed a whole question bank, which will make available for those who are going to go for the January exam. For those who are going to go for the May and September exam, just use the mocks in the portal right now. But for those who want to start preparing for the January exam, we have already started working towards a question bank towards that because of the MCQs. So doctors, currently the May exam will be on May 28th. And then after that, there's a September 17th exam as well. And then the new changes I talked about will be effective on January 14, 2026. So that means that by June 2025, you should start preparing for that exam, right? Because of the new changes and everything. So doctors, we have an early bird discount for you, especially for those who are preparing for the May exam, okay? Early bird. The May exam, the classes will start on March 26th. We'll start with sexual health and obstetrics and gynecology, and then we'll go to cardiology and respirology the next week. We'll go to gastroenterology, genitourinary and general surgery the next week. We'll go to neurology, MSK and rheumatology, and then we'll go to pediatrics and infectious diseases. Then we'll go to endocrinology, hematology and oncology, as well as ethics, and then dermatology, psychiatry, ENT, and ophthalmology. And then we'll do general and final review. We will take a break. And if there is the need for any top-up lessons, we'll do it. An exam day will be on May 28th. So doctors, this is what you have. So if you are planning on taking the TDM exam and studying with MedCognito, what we'll do is that I'm going to share the link for the early bird registration, okay? For those who are going for the May exam, you can just click on the link and then boom, you can just register and you are in the program, just like that, okay? I'm sharing the link right away. So for those who are going for the TDM, I'm sharing the link in the portal, okay? And that is it. So that is the link. And doctors, it's been awesome. Early bird, it's only $1,200 for the whole course. You get access to the portal. You get access to everything in the MedCognito TDM program. Please, if you are interested in the program, don't also forget to send me a WhatsApp right now. +1 306 891 5649. +1 306 891 5649. +1 306 891 5649. Or you can send an email to us at info@medcognito.com. And doctors, we are here to help you. Thank you very much. I'm hoping that this class was helpful. Enjoy the evening. And for those in the MCQ1 program, you have a class tonight, I think in 1 hour time. So thank you that you came to learn something from me. Now go to class and learn more. Learn more. Thank you very much, doctors. Thank you. It was awesome spending the day with you. Now, please go ahead and continue your exam preparation. As usual, this is your friend, this is your companion in your MCQ1 NACOSKI TDM interview prep residency application for the Canadian boards. We are here to guide and help you. All the best, doctors, all the best. So see you in class, and don't forget to take advantage of the early bird discount for the TDM. Early bird discount for the TDM. Thank you very much. Have a wonderful day. Bye-bye. Bye-bye. Bye-bye.